Good afternoon, everybody. Good morning. My name is Christy Duke. I'll be taking over for Brian, who usually does the housekeeping and is the host of the Echo Sessions. Just a few reminders and housekeeping sessions. Let me share my screen with you really quickly. There are CEUs available for this session. So Taloa will share a link. In order to get the CEUs, you have to attend the entire session and complete the evaluation when it's over. And Taloa will put that evaluation link in the chat. We do not have anything to disclose today. No financial disclosures on behalf of any of our speakers. Just a couple of participation tips and housekeeping. We are building a community. If you could please introduce yourself in the chat and make sure you select everyone and not just one person. Let us know your name, your tribal affiliation, job title, and organization. Please don't be offended if we put you on mute unless you're asking a question, just to cut down on distractions. You will also receive a link to the recording and presentation at the beginning of next week. And if you are seeking the continuing education credits, please make sure to complete the evaluation at the end of the meeting. So with that said, we've got a really good session today. Imani is going to go over the information, the data available. Let me stop sharing my screen for a second so I can see her. The current data available on the COVID situation. And then Dr. Brown is going to talk about long COVID. So with that said, I am going to turn it over to Imani. And Imani, I'll make you a co-host so you can pull up your slides. I'll turn it over to Imani so she can give you the current landscape of COVID-19 right now. Thank you.
Thanks, Christy. So I'll actually be doing the presentation on long COVID. I don't have a full-fledged epidemiology update ready for today, as we're also updating the reports, but I will be going over long COVID, and then Dr. Brown will do some clinical updates. So let me just share my screen. All right, I think everyone should be able to see that. All right. So good morning, everyone, and thanks for joining today. As mentioned, I will be covering some information on long COVID and not be giving a full COVID-19 epidemiology update today to have time for that presentation. I will say that the cases have remained pretty low in the US as a whole as of recently, although different areas may be seeing some increases here and there. An update on the COVID-19 surveillance reports. We are still working on revamping these so that they are ready to send out on a monthly basis. And I will say that we are kind of rethinking some of the data points that we had been using in the past in that revamping process, but we are aiming to have a tribe-specific and USET aggregate reports to you by Wednesday, May 4th. So thank you for your continued patience, and please do feel free to reach out if you have any questions about the reports. So as far as today's presentation, I will be covering some information on long-term effects of COVID-19 or post-COVID-19 conditions. This is also known as long COVID or the COVID long haulers. And so given that we have been experiencing somewhat of a shift from primarily focusing on lessening transmission of SARS-CoV-2, which we are still doing, we have been seeing more and more emphasis now on the long-term effects of COVID-19. So that is why I do feel this topic is currently relevant and of importance. And so there has kind of always been some talk around occurrences where there are prolonged symptoms following infection with the virus. From what I remember, like in the early stages of the pandemic, people were saying they were not retaining their sense of smell or taste. So those were some of the very early things that I remember hearing or seeing in the pandemic. But over time, and being in this pandemic for over 2 years now, we really have had the chance to gather some data and evidence, though we still do keep in mind that we're still learning about COVID-19 and its clinical manifestation as a whole. So I've listed out some objectives here that I would like to cover today. Just defining the clinical case criteria of post-COVID-19 conditions, expanding our knowledge on the types of post-COVID-19 conditions, trying to get a better understanding of the scientific background behind long COVID, take a look at the epidemiology that's available, briefly explain the relevance of MISC, review the latest literature involving the long-term effects of COVID-19, and then also try and highlight the importance of post-COVID-19 surveillance regarding public health prevention and treatment efforts. So pretty much starting off with some information, again, regarding the clinical case definition of post-COVID-19 conditions. Here we have the World Health Organization, or WHO, clinical case definition. This was derived from a Delphi consensus, which came out this year, but it does define post-COVID-19 conditions as the illness that occurs in people who have a history of probable or confirmed SARS-CoV-2 infection, usually within 3 months from the onset of COVID-19, with symptoms and effects that last for at least 2 months. The symptoms and effects of post-COVID-19 condition cannot be explained by an alternative diagnosis. So really focusing on the usually within 3 months from the onset of COVID-19. In other words, illness or symptoms that we recognize as post-COVID-19 conditions will usually start 3 months from the time of infection, and then those symptoms can last for at least 2 months. So talking a little bit more on the Delphi consensus itself. It was a prospective study that included a Delphi consensus seeking exercise with representatives from all WHO regions, as well as a mixed iterative survey of internal and external experts, patients, and other stakeholders. Delphi methodology can best be described as kind of like an organized communication technique. It was first used as a structured kind of interactive way to forecast by hearing out what a panel of experts have to say. And so this type of consensus, the Delphi consensus, has been frequently used in research and also has noted advantages over other forms of structured forecasting approaches. But the study itself resulted in 12 domains that are said to be available for use in all settings. They selected 11 domains in the first round and then added an additional domain to bring it up to 12 total. And so findings from the study also identified common symptoms of post-COVID-19 conditions. These included fatigue, shortness of breath, cognitive dysfunction, amongst others that usually affect everyday functioning. In addition, it was found that symptoms may be a new onset after recovering from COVID-19, or the initial illness could persist or continue. It's also possible that symptoms can kind of fluctuate or relapse as time goes by. So you may notice that I do have the 12 domains listed here, and the bolded print corresponds to consensus being achieved in round 1. The italicized is round 2, and then the underlined is after the Delphi panel discussion. So that is what WHO came up with as far as a case definition. When you go to CDC's website for post-COVID-19 conditions, you see where they describe them as an absence of returning to a normal state of health following acute COVID-19 illness, as well as an umbrella term for the wide range of health consequences that are present for 4 or more weeks after infection with SARS-CoV-2. And then it's also described as new and ongoing symptoms as well. So after looking at both of these descriptions for post-COVID-19 conditions, I will say that there is some overlap, but again, we are still in the early stages of kind of understanding long-term COVID and deciding on a central or main clinical case definition that's agreed upon. Moving on to the types of COVID-19 conditions or sequelae, and sequelae means the after effect of a disease, and in this case, that would be COVID-19. So the symptoms that happen after initial infection, like what we saw with the Delphi consensus study, fatigue and difficulty breathing or breathlessness are listed as common symptoms reported in those with long COVID, though we also noticed that the post-COVID-19 conditions can manifest as a combination of these symptoms as well. So the CDC does have some information available for healthcare providers and the general public regarding long-term COVID, and these are the symptoms that they have listed. So in addition to dyspnea or increased respiratory effort and fatigue, there is post-exertional malaise, which pretty much involves symptoms getting worse after physical activity, maybe exercise, walking, or symptoms can get worse after mental activities, perhaps after a long time of focus or being in thought. But this can also pertain to any type of mild exertion, so it doesn't have to be a difficult task or activity per se. But with post-exertional malaise, the symptoms will usually get worse after 12 to 48 hours after activity and potentially go on for days or even weeks at times. Alongside that, difficulty thinking or concentration, also known as brain fog, is noted, as well as cough, chest pain, abdominal pain, headache, palpitations and or tachycardia, arthralgia, myalgia, which is joint and muscle pain, as well as paresthesia, diarrhea, insomnia, fever, lightheadedness, rash, changes in mood, and then anosmia, which is loss of smell, dysgeusia, change or loss of taste, and lastly, a change in menstrual period cycles. So I quickly wanted to draw your attention to the word cloud, where again, we are seeing a lot of the same symptoms presented that I have listed to the left. So we do know that people who have had severe illness with COVID-19 can experience multi-organ effects or autoimmune conditions over a longer time. And they also can have symptoms that potentially last weeks or even months after having COVID-19. Multi-organ effects can influence many, if not all, of the body systems, including heart, lung, kidney, skin, and even brain functioning. And so over 10 different human systems or human organ systems or aspects of human health are affected by long-term COVID-19 health outcomes, which really highlights the complex pathology of COVID-19 in itself to me. So I really won't dive too deep into this portion of the presentation, as I am not a molecular biologist or clinician, but that being said, I will touch on some of the scientific background and the proposed mechanism of action for how these human systems are impacted by long COVID. So the information you see was obtained from a study that postulated mechanisms of action by exploring possible molecular processes associated with the disease outcomes or symptoms. In general, we know that COVID-19 is still depicted by cytokine storm that results in endothelial inflammation, microvascular thrombosis, as well as multiple organ failures. And we also know that multiple organs, again, are affected by COVID-19 due to its wide array of its symptomology. So there's a review by Silva et al. From 2021, which speaks to adverse post-COVID health outcomes and potential long COVID effects. And they did find that multiple human systems were affected rather than just one solely. And so you see those systems listed here listed here with associated long-term COVID complications on this slide. And I do want to note that this article took on a multi-omics approach that included a bibliographic search and review as well. And then they were able to access reported symptoms, comorbidities, as well as possible long-term complications from COVID-19 with above 90% precision, which is excellent. Continuing on a bit more with the Silva et al. Up-to-date review, this is a graphic that I thought would be worth sharing. It shows the geographical distribution of the studies used in the review and the number of articles reviewed per human body system. And so this map shows the countries where the articles were produced, as well as their respective approaches to human body systems affected by post and long-term health complications associated with COVID-19. So looking at the US in particular, we see that the majority of the articles produced involve the cardiovascular human system, followed by respiratory, and then maybe a close tie between hematological and gastrointestinal, followed by the nervous system. Taking a quick scan of the rest of the map, we also quickly see that articles on long COVID and the cardiovascular system do make up a big portion of countries' pie charts. It also looks like the respiratory system was also frequently referenced globally in general. India and Spain stand out to me specifically as they both seem to have more immune system articles related to long-term COVID-19 compared to the other countries. So what is going on a molecular level? This up-to-date review did explore that, and so I will briefly go over the possible ways that systems listed on the slide are affected. Very briefly, and again, keeping in mind that I'm not a molecular biologist, but I did want to take the time to kind of speak on some of the molecular mechanisms of action in relation to the various body systems. So with the cardiovascular human body system, when a myocardial injury is concerned, it usually involves the cardiopulmonary and vascular system in some way. And so the review does reference that myocardial injury is detected in 25% of hospitalized patients with COVID-19 and is also associated with an increased risk of mortality. It also appears that the occurrence of major cardiovascular events such as a heart attack, acute myocardial infarction type 1 and 2, associated with infection does significantly increase the risk of a cardiac injury. So that makes sense, as we know that comorbidities do increase COVID complications. And so, yes, that does make sense. COVID-19 has at least 5 commonly accepted pathophysiological mechanisms which impact the myocardium, or the muscular wall of the heart itself. And those mechanisms include the rupture of atherosclerotic plaque observed in type 2 myocardial infarction, the imbalance between myocardial oxygen supply and demand in type 2 myocardial infarction. And with MI2, there are 4 specific mechanisms related to COVID-19 that also seem to be relevant. I won't go into those here, but then the last 3 mechanisms that are noted include generalized infection or sepsis, lung injury, and then respiratory failure. And all of those are related to severe physiological stress that may be associated with elevations in some of the biomarkers related to tension and myocardial injury too. And so we also know that the widespread occurrence of inflammation in the body is also a cause of myocardial injury, so we do keep that in mind as well. So with the pulmonary system, which includes your lungs, a major organ in the respiratory system, we see with post-COVID-19 conditions that it appears the lungs may experience a gradual functional failure as indicated by hypoxia and other pathological findings found during autopsies. We do recognize that severe respiratory failure and complications involving the respiratory system are some of the more aggressive events associated with an intensified immune response caused by viral infection. And really the results from a study that are also referenced in this review indicate the presence of diffused bilateral alveolar damage, or DAD, in all patients with SARS-CoV-2. Furthermore, there is some new evidence involving an analysis of co-expression data from human lung cells, and that revealed that there are 3 physiological systems directly involved in the pathogenesis of COVID-19, and those are the kinin kallikrein system, the renin system, angiotensin 3, and the coagulation system co-expressed by HH2 receptor in alveolar cells. So in sum, When SARS-CoV-2 infects the lungs of those severely ill, it can induce respiratory failure, acute cardiovascular failure, and coagulopathy. As far as the hematological body system goes, during post-COVID-19 illness activity and accumulation of angiotensin II, which causes vasoconstriction, as well as inflammation and tissue fibrosis are also noted. And so I would say it's very important, again, to really try and understand how each of these human body systems is affected by COVID-19, as they really they contribute greatly to the homeostatic balance or maintaining a state of equilibrium. So still much is to be learned, but we have made some progress. I wanted to take the time to cover some of what we know now as far as the epidemiology of post-COVID-19 conditions. The true incidence and prevalence of long COVID is still to be determined, but that being said, some have tried to estimate these measures. So I have seen the incidence of post-COVID-19 conditions in those infected by the virus from an outpatient or home setting referenced as 10 to 35%. And then alternatively, for those that were hospitalized, the incidence of post-COVID-19 syndrome may be closer to 80%. So definitely higher in those that were hospitalized due to severe illness. There's a cross-sectional study that came out in 2022 this year that mentions the potential prevalence of post-COVID conditions and states that that prevalence was 14%, which was less than what they had expected and when compared to other studies. And it does appear that long COVID is more prevalent among women when compared to men in some of the studies coming out. But when discussing adolescents and children specifically, research indicates that post-COVID-19 conditions may be less common in children and adolescents compared to adults. So regarding post-COVID-19 conditions and vaccination status, the CDC pretty much states that although media articles have been reported that some people with post-COVID conditions say their symptoms improve after being vaccinated, studies are still really needed to determine the effects of vaccination on post-COVID-19 conditions. And so even though COVID-19 vaccines are successful at greatly reducing the rates of serious illness and death caused by COVID-19, they are not as effective at completely preventing the disease, and long COVID can arise even after a mild or asymptomatic coronavirus infection. As I mentioned, post-COVID-19 conditions appear to be less common in children, but MIS-C, or multi-system inflammatory syndrome, in children is documented and relevant, primarily because it can result in post-COVID-19 conditions if the multi-organ effects are prolonged in nature. You can do an entire lecture on MIS-C in itself, but we will not be going down that road today. And in general, the definition for MIS-C can be defined as a rare condition experienced mostly by children, where different body parts can become inflamed during or right after a COVID-19 infection. So I wanted to go over just a couple more articles that I came across that have come out recently. The first one focuses on factors that anticipate post-acute sequelae of COVID-19, or PASC, by Yapeng et al. The authors describe COVID-19 conditions as an emerging global health crisis, which I agree with, since again, many have started to center their attention on the long-term effects of COVID-19 in recent times, as well as due to the how widespread the set of conditions are. So in this longitudinal multi-omic study, they did find that post-acute sequelae of COVID-19 was associated with autoantibodies, viremia, and comorbidities. And they followed 309 COVID-19 patients from their initial diagnosis to 2 to 3 months later, or convalescence. As far as the demographics go, the mean age of participants was 56, and it does appear that all races were represented. We can note that the reactivation of latent viruses during initial infection really may contribute to our overall understanding of post-acute sequelae of COVID-19, so that is something to keep in mind. But during the exploration of early factors potentially linked to post-acute sequelae of COVID-19, it was revealed that subclinical autoantibodies negatively correlate with anti-SARS-CoV-2 antibodies. So as autoantibodies go down, viral antibodies go up. It was also found that gastrointestinal sequelae of post-COVID-19 distinctly present with post-acute expansion of cytotoxic T cells as well. And so the authors state that they resolved on 4 PASC So the authors do state that they decided on 4 PASC anticipating risk factors at the time of initial COVID-19 diagnoses, and those were type 2 diabetes, SARS-CoV-2 RNAemia, Epstein-Barr virus viremia, as well as specific autoantibodies. And their analysis consisted of looking at the symptoms and their association with immunological signatures, which revealed that there was coordinated immunity polarization into 4 endotypes, and those endotypes exhibited divergent acute severity and post-acute sequelae of COVID-19. Taking a look at the visual to the right of the PowerPoint text, we see a few things to make note of, as it kind of gives you a high-level view of what the study accomplished, including the early factors that may anticipate post-COVID-19 conditions, the data used to support the study, and the prospective nature of this study in itself as well. So I found this article to be quite interesting, as we know something about the relationship between having existing medical conditions such as diabetes, heart disease, obesity, etc., and initial COVID-19 severity. So now we see that there may be evidence that COVID-19 also leads to chronic conditions, which is concerning. Having diabetes may increase the severity of COVID-19 illness, and then the flip side of that, where COVID-19 possibly increases your risk for diabetes. However, at this time, the risks and burdens of diabetes in the post-acute phase of COVID-19 have not been completely characterized yet. So again, still research to be done, but this is what we are seeing. And so in the Z and Al-Aly study, they included a cohort of 181,280 participants who had a positive COVID-19 test between March 1st, 2020 and September 30th, 2021. These participants were obtained from national databases of the U.S. Department of Veterans Affairs, while the historical controls of patients from 2018 to 2019 were also used as a comparison group in this study. So they used inverse probability weighted survival analysis to estimate the post-acute COVID-19 risk of incident diabetes, anti-hyperglycemic use, and a combination of the two of those proposed outcomes. And so the major findings from this study were that people with COVID-19 showed a 1.40 increased risk of incident diabetes and excess burden of incident diabetes at 13.46 per 1,000 at 12 months. In regards to anti-hyperglycemic use, there was a 1.85 increased risk and excess burden of 12.35 per 1,000 at 12 months. It does appear that people 65 and older had higher risks and burdens than those who were younger than 65. Black participants also exhibited higher risk and burdens than white participants, as well as those with chronic medical conditions, including cardiovascular disease, hypertension, hyperlipidemia, or prediabetes, versus people without those conditions. And so another notable finding from the subgroup analysis was that even people with a low risk of diabetes before exposure to COVID-19 can have increased risk compared to both contemporary and historical controls. So again, this is very interesting to see that. In sum, this work really emphasizes the importance of post-acute COVID-19 care, especially in identifying, preventing, and managing diabetes as well. So as I come to a close, I just wanted to end on public health and clinical implications for the prevention and treatment of post-COVID-19 conditions. Prevention of post-COVID-19 conditions remains the same as initial COVID-19 infection prevention. Avoid infection and reduce the spread of COVID-19. If you can, get vaccinated and boosted. As we do know, the COVID-19 vaccines are effective at preventing severe illness from COVID-19 again. And of course, we cannot forget our trusty public health prevention measures: physical distance, washing your hands and or sanitizing them, and wearing a mask if possible. At first, many really just thought of COVID-19 as a respiratory infectious disease, but due to the degree of reported post-COVID-19 conditions, we are seeing it may very well be more chronic in nature. So that being said, treatment does remain an important pillar in patient care and public health. Many post-COVID-19 conditions are manageable by primary care physicians, and so we are aware of that. And the CDC does provide some interim guidance for healthcare professionals, which includes trying to understand the impact that these types of conditions have on patient care, while also providing clinical care with a patient-focused approach so that we can maximize quality of life as well as functioning in those that are impacted. And then not using objective laboratory or imaging results as the sole measure for a patient's well-being or state of health. If needed, you can also create management plans to address several areas or aspects of health, including physical, mental, and social, if you would like to do so or feel that it's needed. And really just working together with patients to identify and reach attainable goals through joint decision-making. And lastly, staying up to date with the latest guidance for healthcare professionals, which will, I would think, likely change. This is more of an FYI, but since July 2021, post-COVID-19 conditions can be considered a disability under the ADA, and more information can be found at the link on this slide. So just an FYI with that. And also accompanying that, in regards to public health, we really must try and continue to prioritize surveillance of post-COVID-19 conditions and initial COVID-19 infections so that we can establish the true burden of disease and increase awareness on the impact long COVID has had on public health. And accompanying that, we also need to continue conducting longitudinal research that explores the science and clinical background of long-term COVID, as that will also assist in addressing critical aspects of patient care as well. So that is all that I have. These are some helpful links and resources that I mentioned throughout the presentation from CDC and WHO. And then I also have references to, I believe, all of the articles that I talked about as well here. I will take any questions now, and I may call on my wonderful colleague, Dr. Brown, and his expertise if there's something that I am unable to answer in regards to the science of some of these mechanisms. Okay. Okay, not seeing any questions, so I guess I will pass it along to you, Dr. Brown.
Thank you, Imani. That was a really great presentation. I think from now on, if you present you have to go after me because I don't want to follow such a good presentation. It's going to be hard to equal that. Yeah, it's amazing to me that, 27 months ago, I'd never heard of COVID-19 and just the explosion of knowledge that has come about because of this virus. I'm just going to do a few clinical updates today. If you could go to the next slide. Yeah, today is day 759 for those of you who are keeping up, or I guess I'm keeping up for you if you're not. Yeah, we're 25 months now into the pandemic. So on this day 759, I'm going to talk a little bit about variants, the BA.1, but really the BA.2 is what I'm going to talk about. Give you an update on some therapeutic agents and also on vaccines. So if you could go to the next slide. So to start with variants, Omicron, which nobody had heard of until around Thanksgiving, it really has at least 3 subvariants that have come about, really maybe 4 if you count BA.3, which is pretty small in its occurrence. But the original one was dubbed BA.1.1.529. But there was one that was a little bit different, named BA.1.1 without the 529. And then BA.2, which shares a lot of the same mutations, but has several unique mutations of its own, but is still considered an Omicron subvariant. On the left of this slide, this is from the CDC, and you can look at it for yourself if you click on the reference there. But this just shows since Christmas, so over the last 3 months or so, you can see how, first of all, Delta, which is the little orange slice there at the bottom, has gone completely away. Delta only accounts for about 1 in 1,000 cases at this point in the US. But gradually over time, BA.1, which is the really dark purple line at the top, has been slowly replaced by BA.2, which is the, I don't know if that's pink or light purple at the bottom, but you can see how BA.2 has increased and BA.1 has decreased. So BA.2 is now accounts for about 86% of cases worldwide. In the US, it's a little lower, but as of a week ago, it accounted for a little over 72% of cases, so almost 3 out of 4. Omicron is virtually the only thing that's around these days. Next slide, please. So should we be worried about BA.2? I've gotten this question a lot recently. I think it's been in the news a whole lot. It does seem to be even more contagious than the first Omicron subvariant. That one caused that huge wave this winter. So the fact that this one is more contagious, are we going to see another huge wave in the next couple of months? That's a question that's on everybody's mind right now. Fortunately, BA.2 does not really seem to behave any differently in terms of symptoms or number of hospitalizations or death. As to whether or not we're going to see another huge wave, most of what I'm reading, the speculation is that we will not. There is an increase in cases right now in New York City and some other places around the country, but that uptick has been pretty small so far, and there has not been an uptick in hospitalizations. So most epidemiologists at this point believe we're not going to have another huge wave. And that's probably because if you were infected with BA.1, you have immunity to BA.2, at least a lot of immunity to it. There have been very, very few cases of BA.2 among people that had BA.1 previously. Now, one of the things to know about BA.2 that's different, it doesn't have the S gene dropout on some PCR tests. If you will recall, some of the PCR tests that are used test for the S gene. And because the tests were developed with the original virus and because Omicron had so many new mutations in the S gene, it caused these PCR tests to not pick up the S gene. So that gave you a clue that you were dealing with Omicron. This isn't really all that significant, but BA.2 actually doesn't have the S gene dropout because it has several mutations in the S gene that are different from BA.1. Anyway, all that is to say that you can't rely on that S gene dropout to say, oh, this is Omicron, or oh, this is not Omicron. There's a really good Scientific American article about BA.2. If you want to know more about BA.2, I encourage you to read the article that I've put the reference there on the slide. It's a well-written article that's easy to understand, even if you don't have much of a scientific background. So bottom line is, we don't really need to be any more worried about BA.2 than we were with the original Omicron. Next slide, please. And this is just the current case trend in the US. We've been at a plateau now since the middle of April, somewhere around 25,000 new cases a day. That's way less than the 800,000 new cases a day, and sometimes over 1 million new cases a day that we were having back in late December, early January. So right now we're experiencing low levels, but it has plateaued. Next slide, please. So what's new as far as therapeutics? Well, one of the newer monoclonal antibodies has already come and gone. Sotrovimab, which was the only one that was effective against the original Omicron, has now lost its EUA from the FDA because it's not very effective against BA.2. And we're now seeing BA.2 all across the country. It's the predominant strain. Sotrovimab may have some effectiveness, but apparently the effectiveness is not good enough for the FDA. So they have revoked the EUA. So don't use Sotrovimab anymore. Next slide, please. So what can you use? Well, currently, for someone who's early in the course of COVID, especially if they have risk factors that might put them at risk for higher incidence of hospitalization or severe COVID, there are some things that are available. Bebtelovimab, which is a new monoclonal antibody that's just come out, that is effective against BA.2. I'm not sure how available it is. I haven't had any experience with it. I don't know if any of you have or not. There's nirmatrelvir and ritonavir, probably better known to you as Paxlovid. This is a pretty highly effective oral drug that, if given early on, can prevent more than 80% of hospitalizations. The sort of big precaution here is that it has a lot of drug interactions, so you really need to check for those before prescribing it. Molnupiravir is another oral antiviral agent that has some okay activity, but not nearly as good as the Paxlovid. Molnupiravir is only about 30% effective at preventing hospitalization. So this would, be my choice only if there was nothing else to give. There is IV remdesivir. Unfortunately, it's only IV, and you have to give it once a day for 3 days straight. So although it's highly effective, in fact, at least, if not more effective than Paxlovid, it is logistically a challenge to get somebody to come in, 3 days in a row to get an IV infusion. If you're not familiar with the Test to Treat program, this is a recent development by the federal government. This is a program, certain pharmacies around the country, people can go there, get a test. If the test is positive, they can get medication, usually Paxlovid, before they leave. And there's this, I've put a link to the Test to Treat locator. If you click on that, it'll take you to a website. All you have to do is type in your area code, and it will show you the nearest places you can go to get this. I actually tried it myself, and there's a pharmacy just a couple of miles away from where I live here in Western North Carolina, that if I was having symptoms, I could go there, get a test, and if it were positive, they'd give me medication. If I met the criteria. Actually, I'm not sure that I'm high risk enough, but maybe I am due to age, I don't know. I've put another link there at the bottom that just is a link to the FDA page that lists all of the EUAs for all of the therapeutics that we currently have in the US. Next slide, please. So on the vaccine front, excuse me, just the only thing I'm really going to talk about today is the second booster that's been recommended by the FDA and CDC. I've been getting a whole lot of questions on this from patients, colleagues, and family members. I don't have any news about Novavax or the Sanofi GSK vaccines that are the protein subunit vaccines, and no news about pediatric vaccine for the under 6-year-old group. Hopefully in another month, we will have some news about those things. So next slide. So Israel started giving a second booster dose to people in the 60 and over age group early in January. And then just a little over a week ago, on March 29th, the FDA and CDC recommended that everybody over 50 and everyone who's over 12 with certain immunocompromising conditions get a second booster shot. Now, this has been met with some skepticism. And in fact, the European CDC and the European Medicines Agency, which is their FDA basically, they are only recommending second boosters for people over the age of 80, as well as people who have severe immunocompromising conditions. I'm going to go into why this has been a little bit controversial. So next slide, please. Pardon me for just a minute while I plug in my laptop, or it's going to go dead and I'm going to go away. I have learned that with the Surface Pro, when it says your battery's running low, you've got about 2 minutes to plug in, or you'll be without power. Okay, saved by the charger. My apologies for that. I had it fully charged this morning, but I guess I've used up the battery power. So just a couple of days ago, April 5th, there was an article in the New England Journal that outlined the Israeli study that was the one that led to the FDA and CDC approving this. They had early access to the data from that study. But so Israel started giving people back in January a fourth dose for those who qualified, people over age 60. And they've now studied 1.25 million people. This was a big epidemiologic study. They looked at people over the age of 60, both those who had been vaccinated 4 times, those who had been vaccinated 3 times. And what they found was that if you compared people who had gotten a fourth dose to people who had only gotten 3 doses, in other words, just 1 booster dose as opposed to 3, that if you looked at them 4 weeks after they received this 4th booster dose, the ones who had gotten the 4th booster dose were about twice less likely to have any COVID infection, and they were 3.5 times less likely to have severe COVID. Now, what they also noted as they followed these people out over time was that by about 2 months after the 4th dose, that the protection against infection was about the same as people who had only had 3 doses, but that protection, that higher level of protection against severe disease did not go down. So that was kind of an interesting finding. Next slide, please. Now, here's a little more evidence that, is different, but this just came out yesterday. Another Israeli study that was much smaller, and this was a non-randomized study. It involved about 1,000 healthcare workers. So some of them got a 4th dose of Pfizer-BioNTech, some got a 4th dose of Moderna. And they looked at their antibody levels, and they saw that it really did boost antibody levels for a short time. However, there wasn't a whole lot of protection against infection. And the people who got infected had fairly high viral loads, which meant that not only were they infected, they could also pass it on to others. But vaccine efficacy for these people was only about 11 to 30%. Now, a lot of them didn't have any symptoms. These are people that they were testing on a weekly basis with swabs and, doing PCR tests. A lot of them were asymptomatic, so the vaccines did seem to protect against symptoms, and they didn't get very sick. So there was about 31 to 43% vaccine efficacy for symptomatic infection. They also didn't note any safety issues in this study or that much larger study in Israel. So that's sort of on the good side. I've put references to both these New England Journal articles here, and you can get those online, even if you don't subscribe to the journal. Next slide, please. So bottom line, what should we do? This is what I'm being asked, and I'm even, for my own self wondering, do I get a 4th dose or not, So a second booster dose does appear to increase protection for older people from infection for a short time. It may increase protection against severe disease, though, for a longer time. So I think in, older patients, FDA said 50 and older, Israel says 60 and older, Europe says 80 and older. But anyway, for older people, especially if they have comorbidities that put them at higher risk of bad outcomes, I think a 4th dose or a second booster probably is a good idea. But young, healthy individuals appear to have little benefit from a second booster, so they really don't need it. Now, the good news is that in people who have received a 4th or even a 5th dose, they haven't noticed any safety concerns, so people aren't cropping up with new, bad side effects. But here's the real bottom line in my mind. There is a definite benefit to getting vaccinated with a primary series and getting 1 booster dose. So I think this is where we really should concentrate our efforts, is getting everybody, fully vaccinated. And then when they reach that 5-month or so after their primary series, giving them a booster. And this seems to confer long-term protection for most people against severe disease, not against infection, especially with these new variants, but it does keep people out of the hospital and out of the morgue. Next slide. And I think that's all I have today. I think we have a little bit of time for questions if anybody has any, either about long COVID or these clinical updates. But thanks very much for your attention, and I hope everybody has a great weekend. So any questions? Or any discussion?
Thank you, Dr. Brown, for a great presentation. If anybody would like to chime in, if not, we will talk to you later. Please don't forget the evaluation link. Talo has reposted it to get your CEUs. This will be posted on our website early next week. Let's hear it, Mike.
I just wanted to say hello to Dr. Brown. I haven't talked to you in a while.
Yeah. Nice to see you.
It's ever evolving. It's very confusing for our patients, and you know what I had read last week when the fourth booster was being talked about was that the FDA approved it, but then didn't recommend it. They basically said it can't hurt you. So has that changed? From your presentation, it sounds like they're now recommended, because the message we're given to our populace is it's available. We have authority to give it to you if you want it over 50, and then over 12 in consultation with your provider. So that's kind of the message we're putting out right now.
And, I think that that's a reasonable message. I do think that for older people, especially those who are high risk for reasons such as, living in a nursing home, or, they have a lot of comorbidities, medical conditions that make them a higher risk. I think a fourth dose for them at this time is appropriate. For some, a healthy 55, 60-year-old who isn't high risk, I wouldn't. Getting the unvaccinated vaccinated, because we do know that, being vaccinated protects you against severe disease.
Right.
So, yeah, as far as timing it too, right now cases are low. Do you want your short-term immunity to run out before the cases go up? But on the other hand, by the time the cases go up, then, the risk is higher. So, it's kind of like timing the stock market, or I've heard that analogy is not original with me. I've heard other people say that. Does that answer your question? I know I'm waffling a little bit there, but
well, it definitely matches what we're kind of our philosophy is right now. There are a lot of questions. There's some rumors I've read in some opinion pages that, is there any truth to this, that it's anticipated that we will have a vax in the fall that combines the flu and COVID. And people are asking that with the timeliness, should I, we know the next wave is coming. Do we have enough warning? Then I'll get the fourth boost. We just kind of like, yeah, we don't know,
Yeah. And, the only data that we really have, the only real evidence we have are those studies from Israel that I alluded to. I would urge people, providers, I would urge you to read those articles and come to your own conclusions. my conclusion is, yeah, for high-risk older people, I'm going to strongly encourage them to get a booster now. For those who are less at risk and younger, I think it's, if they really want it, sure, there's no harm in getting it. But I'm not going to push it. I'd rather spend my efforts on convincing unvaccinated people to go ahead and get vaccinated.
Dr. Brown, it looks like Bernice has a question in the chat that she heard something similar about the symptoms of fibromyalgia. Have there been increasing diagnoses of this?
I don't know specifically about fibromyalgia. Amani might have some information on that because she's done so much great research on long COVID. It wouldn't surprise me.
Yes, from what I remember, it is noted fibromyalgia as an effect. So, but I may have to do a bit more. I'm sorry, Bernice, what is your question, I guess? That just that symptoms are.
Yeah, just general. I was just curious, Amani. I just caught something about fibromyalgia. I know there's a lot of things that are pretty similar. You know, some of the symptoms are pretty similar with what they diagnose as that. So just curious to hear if there were any other, you know, if that has increased, because it depending on what health professional you talk to, they have their own bias about fibromyalgia. So it was just a talking point. That's it. I just wanted to know if you knew anything more.
Yeah, yeah, I can definitely say that it is noted, but I am unsure on if it's had an increase at all.
I would be surprised if people who have fibromyalgia and they get COVID, if they don't feel a lot worse with their
Dr. Brown appears to have frozen on us, and no, I don't think he dropped off. There he still
increases rheumatoid arthritis diagnoses. That's one of the post-COVID symptoms. And Anawa is saying yes, from personal experience, it makes it worse, at least for a while.
All right, are there any other questions? Okay, don't forget the evaluation. Taloa posted it above, and thank you, and everybody have a nice weekend.